are here in Masters Spoke Out Studio in Cardio Alex 23 in Bibliotheca Alexandrina. We have the pleasure and the honor to speak to you. I hope the subject will be beneficial. With me is Professor Edward Fry from Indiana, United States, Professor of Cardiology and Intervention, and with me Professor Hassan Khalid Nagi from the Critical Care Department, Cairo University, and expert in intervention. We choose the subject of myocardial infarction. I will start by speaking about the precautions and the risk factors and how to prevent it. The risk factors for myocardial infarction are smoking, the killer number one, high lipids, especially not only cholesterol and triglycerides, but LDL. The normal should be below 100, but people don't know this, and we see even above 190, which is a very critical level. The second cause, or the third, is diabetes, and third, fourth, hypertension, obesity, and stress, and lack of exercise, and high calorie diet. So we hope the patients follow the rules and control no smoking, control blood pressure, control diabetes, control lipids by statins, the drugs that are available in a good price and minimal side effects, so we can prevent. After prevention, we have to speak about symptoms. The patient gets angina on effort, and sometimes it is in the epigastrium and think it is stomach, but it is can be from the heart and gives pain in the epigastrium, radiating to the left shoulder and also the right, and radiating to the back, compressing in character, and comes with effort and relieved by rest, but sometimes we see the pain even at rest. Associated with sweating, vomiting, syncope. If it is persistent more than 15 minutes and does not subside by 2 tablets sublingual nitrates, it is high probability of myocardial infarction. In this case, the patient must be admitted to intensive care and ECG to be done immediately. And we have to teach the patient that within 1 hour of the infarction, he must get intervention and dilatation of the occluded vessel. The patient now went to the hospital. I will give the talk to Professor Hassan Khalid to speak about when the patient is admitted to the hospital, what he will do for him.
Thank you, Professor Samir. Actually, every patient admitted with ST elevation myocardial infarction should receive 4 aspirin, which means 300 milligram aspirin, 4 clopidogrel, which means 300 milligram clopidogrel, low molecular heparin like enoxaparin or fondaparinol, and he should receive to relieve the chest pain by nitrate, if possible by morphia. Nitrate should be given sublingual or intravenous when blood pressure allows. If low blood pressure, it cannot be used. It can be given subcutaneously, it can be given by intravenous or oral. After that, the only way to treat myocardial infarction, class 1 indication, is revascularization. The best way of revascularization within the first 2 to 4 hours is by PCI, percutaneous coronary intervention, which means we introduce a patient into the lap, coronary lap, and by a wire and a balloon, we open the occluded target vessel, which will decrease the area of jeopardized myocardium and decrease myocardial damage and relieve the chest pain. Actually, this should be done in the first few hours if there is ability to find a lab inside the hospital or nearby by half to 1 hour. If not, and it's not available, you should give thrombolytic therapy, which is successful in 50% of cases. Unless, if not, we have to do rescue PCI in the nearest hospital. If it's successful, we can, within 1 day, refer to another hospital with PCI facility, because there may be a critical stenosis or thrombus over it with dissolves the thrombus by thrombolytic therapy, but the stenosis is still there, which may happen that he has again thrombosis and MI. So if thrombolytic succeed, we have to refer also to PCI. The importance of being in a hospital, every patient with acute ST elevation should be in ICU or coronary care unit in the first 24 to 48 hours, because there is a lethal arrhythmia called ventricular fibrillation, can happen in 2 to 5% of patients, and can be treated immediately by cardioversion if inside the hospital. If outside, the patient may die suddenly. That's why every patient should be hospitalized to prevent the sudden death by VF, which happen rarely, but if happen, it may lead to sudden death. Okay.
Thank you very much, Dr. Hassan. You illustrated the rapid indication for intervention. Now, the physician referring the doctor, the patient must know what are to expect, how the percent of success, the percent of failure, the complications. Professor Edward Fry will speak to us about the probable complications that can happen with myocardial infarction before, during, after intervention.
Great, thank you, and thank you for your comments in both scenarios. So I think important to consider the risk of complication in the short and the longer term. So certainly in the hospital, the shorter term was just mentioned, the arrhythmia risk. One of the ways to certainly reduce that risk is with early revascularization and stabilization. But to best assess what level of risk patients will be at is to establish what their left ventricular function is. And so whether with echocardiography or during acute catheterization, ventriculography to understand what the ventricular ejection fraction is will be important in terms of understanding at what level of risk patients are with respect to arrhythmia, but also heart failure. Patients should also receive beta blockade in the early going after myocardial infarction, both in terms of LV protection as well as reducing the risk of arrhythmias. The longer term complications, as a patient may be recovering during their hospitalization and ready for discharge from the hospital, would be issues related to congestive heart failure and managing that congestive heart failure with guideline-directed medical therapy in the acute setting if evident, as well as then addressing the other risk factors very aggressively, lipid-lowering therapy with the target LDL cholesterol of below 70, and perhaps, as the new guidelines will now show us, actually to less than 55 in the future. If patients are hypertensive, aggressively lowering their blood pressure, specifically with angiotensin receptor blockers or ACE inhibitors, with a target systolic average blood pressure below 130 and diastolic pressure below 80. There are other types of complications that we don't think about quite as much, and these include depression. Many patients who've had myocardial infarction will develop, about 20 to 25% of patients will develop depression. Other complications that we must address, interestingly, half of patients may not have, who actually have diabetes, may not have a diagnosis of diabetes entering the hospital, and their myocardial infarction is their very first presentation. Aggressively in managing that diabetic situation to lower their complications related both to diabetes as well as their vascular disease will be critically important in that transition from the hospital to discharge.
Precaution to prevent bleeding from the stomach while we are giving many anticoagulants and heparinization and antiplatelets. We have to protect the stomach by controlock or antacids, because we had a case of massive bleeding after catheterization and the patient died. So this is one of the precautions or one of the expected or the probable complications.
Completely agree. And so there initially years ago was concern regarding giving proton pump inhibitor therapy with antiplatelet therapy, with specific P2Y12 inhibitor therapy. But now that's been well established that that is actually helpful in terms of reducing the risk of future bleeding and acute bleeding, which would mitigate problems in the hospital.
Thank you. The probability of occlusion of the stent it is now much less with the use of drug-eluting stents. Can the family of the patient just, if it happens, know that this is not a mistake from the doctor, but probability, how percent can the stent can be occluded? It is very small, I know.
Yeah. Fortunately, in the first 24 hours to 30 days, that risk is very low, 0.5%. The risk of need for acute reintervention is 1% or less, so very unlikely. Although patients may experience some mild episodes of chest discomfort that are not typical of angina in the 30-day period after acute myocardial infarction presentation. Some of that may be pericarditis, some of that may be related to acute manipulation of the coronary artery and the stent itself, maybe as many as 10% of patients may experience such symptoms, but fortunately it's very rare to have an acute occlusion.
So we assure the family and the patient that stent occlusion is very remote. The touch of the kidney, affection of the kidney by the dye that is injected, also it is less than 6%, or how much?
Yeah, acute kidney injury, which is a very sensitive definition, maybe as high as 6%. The actual severe kidney injury leading to dialysis would be very, very low in most circumstances.
Very good. So this is assuring point to the family and the patient. The probability during stenting, we need some dissection in the artery. We need, instead of one stent, 2 or 3, and we will ask the patient and the family to pay more. So they must expect something like this. If we say the cost of the stenting will cost so much, but they may discover that it is higher than this. The possibility it happens that instead of putting 1, we put 2 or 3.
And much of that depends on the extent of the coronary disease present at the time of presentation. On average, maybe 40% of patients will require a second stent.
And if there are more than 2 or 3 occluded vessels or narrow vessels, we have to stent all the vessels or stages.
Recent studies suggest that complete revascularization improves long-term outcomes,
Yes.
and that is best done in the during the index hospitalization.
Very good. So I hope we covered in short time the indication, the precautions to avoid myocardial infarction and the symptoms and the indications to go to the hospital and what to do when the patient is admitted to the intensive care, and we spoke nicely about the probable complications and how to prevent it. Thank you very much for Masters Spoke Out program and studio, and we are happy to be in CardioAlex 23 and happy with the combination of dear Professors Hassan Khalid and Edward Fry. Thank you.